To go to the next speaker, Dr. Hani Sabbour is first is my friend. Second, Dr. Hani Sabbour is well-known multi-specialized cardiologist. He's very well known on all the all the programs, all the meetings. He's electrophysiologist, cardiologist, specialist in hypertension, specialist in pulmonary hypertension, and heart failure specialist. Without any further delay, Dr. Hani, we are very great pleasure to have you with us and to listen to your excellent talk from the beginning. I know it will be excellent from the beginning. Dr. Hani.
Thank you very much, Dr. Sharif. It's always very kind of you, and also Dr. Abdullah and Professor Rosano for inviting me to this very important clinical and very relevant meeting. So my task today is actually to talk about hyperkalemia. So I'm just going to rewind a little bit. So I call this RAAS inhibition, chronic heart failure, hyperkalemia, the big influencer. And I think these are the main highlights of the talk. We'll talk a little bit about prevalence and recurrence, the burden of hyperkalemia, and the therapeutic dilemma, which is at the core of this talk, managing hyperkalemia while still optimizing life-saving MRA and RAAS-I therapy, which was so nicely highlighted by Professor Sabbour earlier. So these are the two balances that we have to consider in clinical practice. So the benefits of continuing RAAS inhibitors: delay CKD progression, decrease MACE, decrease mortality. The barriers of RAAS inhibition, number one actually appears to be hyperkalemia. Number two is acute kidney injury. Three, which is most important, is provider uncertainty and fear and rapid decline in kidney function. And in reality, as we saw from Professor Sabbour's presentation, 40% of patients with CKD don't receive RAAS inhibitors properly, not hyperkalemia. So this, even the perception of this link with hyperkalemia is enough to scare people off. And it's really terrible because you lose a lot of the benefits on here. And there's a lot of solutions. One of them is using potassium binders to facilitate and prevent hyperkalemia, to down titrate ACEs and ARBs, to stop ACEs and ARBs in acute illness, or avoiding other nephrotoxic agents. And of course, we have now some randomized studies that are going to be discussed shortly. So I'm going to start you with, this is a real case, and this is a real interaction. This is a cardiorenal interaction, but it doesn't exactly mean what you think it is. A patient with HFREF, CKD, and hyperkalemia. So I received an email, this is fairly recent, from a nephrologist. Below patient, you increased Entresto last Thursday. Urology wanted to increase K-citrate 2 weeks ago with a stone, which is large and not surgical. Potassium is borderline elevated. Can we postpone the increase in Entresto until next visit and make sure the potassium remains okay? My response: dear doctor, thank you for your feedback. EF is very low, major compliance issues, BNP is not coming down. He has an ICD as well. I would favor a potassium binder in order to keep potassium lower and deal with the stone in a different way. Next response: thank you for your feedback. Lab test next week. If potassium is an issue, we'll switch to oral sodium bicarb, and I'm going to discuss with the urologist. Fourth email. Dear doctors, again, the objective is to enable comprehensive LAS blockade in a patient with LV dysfunction to maintain LV function as a primary issue. I've checked with our clinical pharmacist. We do have potassium binder to maintain the potassium levels. Can we discuss with, this is the urologist, if a surgical option is available, since preserving the renal function is also very important, especially if there's an obstructive element and CCs. So this keeps going on. The urologist now jumps in. I can operate to remove the stones. The patient is not willing to proceed with surgery. However, if we can tell him we cannot safely maintain the urine pH to treat the stone medically, surgical treatment is reasonable, then we can avoid or lower dose of potassium citrate. All of this discussion in order to enable maximizing the dose of valsartan, sacubitril, and RAAS blockade. And this is because of the impact on heart failure, mortality, morbidity, and even renal function. So not a small thing. And this sort of story keeps going on and on. It's endless. In any case, I think you see the point here. Potassium is a very important point of interaction between nephrologists, cardiologists, and other interested patients, physicians. Now, the cardiorenal patients are obviously at risk of hyperkalemia. The more advanced CKD, 50% diabetics and on RAAS therapy. In heart failure, about 40%, especially on spironolactone at higher doses. Diabetics, patients with resistant hypertension benefit from MRA and have hyperkalemia, and it's 2% in the general population. So almost 10 times higher in our cardiorenal patients. The profound negative impact of incomplete RAS blockade, whether that is not titrating or not starting MRAs, means worse adverse remodeling, progression of heart failure, mortality, and in terms of RAS therapy, if you don't manage the hyperkalemia, the outcomes are going to be worse. So by losing any one of these two elements, MRA or RAS therapy, obviously mortality will increase. And that's obviously something we're trying desperately to avoid in the current setup. Now, the MRAs are the first things that disappear, as you saw in the heart failure registries. And that's bad because the MRA has effects on blocking the aldosterone, blocking the angiotensin II, effects on the endothelial dysfunction and fibrosis, direct effects on preventing fibrosis in the myocardium, and also protect the kidney from glomerular injury and proteinuria. So the link between the MRA and improving heart failure and CKD is a very significant one. And therefore, if you look at this concept here, and this is from a recent study from, we'll show you a little bit more about the Fidelio DKD study, which is a novel mineralocorticoid antagonist that doesn't really cause much hyperkalemia. This agent in patients with CKD not only reduced CKD progression, but also reduced CV mortality and morbidity and new onset of AFib by a tremendous amount, anywhere between 30 to 20% in patients with heart failure and CKD. So we really cannot avoid the fact that we need to get rid of the hyperkalemia while still maintaining these therapies. Now, the potassium management has been a major concern in CKD and diabetes studies, and this is sort of Altitude and Fidelio. And the more selective MRA blockers actually have a greater impact on renal and CV efficacy than non-selective ones. I think this is a key point. And if you also look at RAS inhibition in general populations, as well as CKD populations, it's really important to realize that we are losing a tremendous amount of efficacy if you don't give the patients an MRA. So in patients with heart failure and CKD, there's a much higher likelihood of developing hyperkalemia. So those with heart failure are even more at risk of having hyperkalemia than CKD alone. And of course, we have different types of hyperkalemia. The moderate hyperkalemia, which we really watch but don't do much about, and the severe hyperkalemia, fortunately, is less, but of course, of great importance. Now, if you have hyperkalemia in patients with worsening CKD and heart failure, the likelihood is that there's an increasing rate of hyperkalemia when the CKD is worse. So that's very obvious, right? We know this, but that doesn't mean we don't give the life-saving drugs. That's exactly the opposite idea. 25% of patients with heart failure will develop, this is from the Swedish registry, will develop hyperkalemia at some time. It's usually modest, about 5, about 25%, 5.5, about 10 to 12%. Now, in heart failure, hyperkalemia is recurrent. It doesn't just happen once. So these were groups of patients with who are on RAS blockers at least 62% of the time. First, second, and third events with hyperkalemia are present, but do you think it gets less because we are managing the hyperkalemia? No, sadly, the answer is most physicians, what do? They just stop the RAS blocker, and that's very dangerous because we've seen that that actually increases mortality. So in patients with hyperkalemia, most of the mortality is actually driven by the idea of hospitalization for mortality. And that's important because we can't ignore hyperkalemia, particularly when the potassium is very high. In the intermediate range hyperkalemia, a lot of it is driven by hospitalization. And seriously, I think we have a better way to manage the hyperkalemia rather than just to drop the drug. Now, it is fairly clear that whatever group you look at, heart failure, CKD, and diabetes, CKD alone and heart failure alone, the higher your potassium levels, and clearly the cutoff point here, there's sort of this critical region of around 6, where the mortality is significantly higher. Now, the other problem, of course, if you have low potassium, particularly in the heart failure patient, that predisposes to arrhythmia. So potassium really needs to be measured and monitored in a very close range in order to avoid serious adverse events. And persistent, long-standing hyperkalemia, chronic hyperkalemia, is associated with greater mortality compared to those who have achieved or maintained normokalemia. So the risk of sudden death occurs either way, in here above 5.5 or below 3.5. At the same time, heart failure-related deaths, strangely enough, again, above 5.5 and below 3.5. So it really is important to be managed. Hyperkalemia alone does increase hospitalization by 2.8 times, especially if they've had one event. And of course, that's something we have to follow up and treat, not ignore and not get rid of. Healthcare costs in hyperkalemia are significant. So in patients who have hyperkalemia versus patients who don't have hyperkalemia, this is sort of a complicated slide, but the higher your potassium level, the higher in here in blue, the cost of acute hospitalizations than patients who don't develop hyperkalemia. So it, of course, is extremely important. So our back to the basic, the therapeutic dilemma is RAAS blockers in the guidelines need optimization, and that includes RAAS plus MRA. RAAS therapy reduces CV morbidity and outcome and slows CKD progression. Hyperkalemia prevents us from reaching target doses and may in fact lead to the opposite, dose reduction, worse cardiorenal outcomes, and mortality. So I think this risk-benefit calculation we're going to talk about, we're going to try and shift this balance so that we avoid blocking and discontinuing RAAS and still continue the benefits of these agents. So again, this is very clear. We know about these guidelines. There's no question about it. Now, this is obvious. From the RALES study, the reduction of mortality was almost 30% with addition of spironolactone to ACE/ARB and beta blocker. But hyperkalemia increased, almost 50%, in fact, in the spironolactone arm. In the emphasis study, a more selective beta MRA, again, reduced CV mortality and heart failure hospitalization, almost 40%, but hyperkalemia. Here, the serious hyperkalemia I would consider is about 2.5% compared to placebo. The ultimate problem is that when this happens after a hyperkalemic event, what do people do? What do they do when they pull the trigger? Almost the majority of patients will have the medication either stopped or down titrated. The minority, especially if the potassium goes up to 5.5 or above, only the minority are going to have the maximum dose maintained. So we're losing the advantage of mortality reduction in most of the patients when the potassium is above 5.5. Less so, but still happens when the potassium is between 5 and 5.5. Now, what is the evidence that this is bad? Well, if you down titrate or discontinue, mortality actually doubles. So in CKD, from 9 to 22. In heart failure, from 13 to 30. In diabetes, from 5 to 13.1. So whether you discontinue or down titrate, any reduction of RAAS blockade is seriously a problem. And in fact, if you look at this very large study from the ESC heart failure registry, it was the RAAS discontinuation rather than the potassium that was associated with mortality in heart failure after 1 year of follow-up. RAAS discontinuation, 7 times the hazard ratio, baseline potassium of 5.5, 1.27. So the majority of the problem actually comes from discontinuation of MRA, ACE, or ARB, not from the potassium itself. So I think this is very clear, and this is from a heart failure registry. And in reality, stopping the RAAS blockers persists after a hyperkalemia event. How many patients have you seen that don't have an MRA? You look back, 76% of patients were not reintroduced during the next year, and the mean duration of blockage or discontinuation is between 2 to 2.4 years in heart failure and CKD, which is a disaster. So as soon as the potassium goes up, the reflex is to stop the potassium, increasing medication, even though it's life-saving, and then of course you saw the effect on mortality within 2 to 3 years. So the opposite is actually true. If you optimize RAAS therapy in patients with CKD and heart failure, you can certainly reduce mortality and reduce MACE by tremendous amounts. This is really almost double in terms of MACE, almost 10 times in terms of mortality in CKD and heart failure. So again, going back to that point. So how can hyperkalemic patients receive optimal RAAS therapy? Reduce the dose of RAAS, not a good idea. Discontinue RAAS, even worse, or treat the hyperkalemia and maintain and optimize RAAS therapy. I think this is the wave of the future. Not reduce, not discontinue, but treat and maintain long-term optimization. Now, the new approach comes from new medications as well. So we have this medication, it's called finerinone. It's a novel MRA where the risk of hyperkalemia in the low and intermediate doses, 1.2 and 2.5, is in fact approximately 3%. Placebo is in fact 1%. But the reduction of microalbuminuria in this study and maintenance of kidney function was significantly greater. Now, sometimes you might have seen this. This is recently published, finerinone. This is another novel MRA. Fidelio DKD was the study, and they enrolled patients with type 2 diabetes, CKD, on maximal ACEs and ARBs. And in fact, these patients had persistent albuminuria and low GFRs between 25 and 30. And of course, this was a renal study. But of course, what happened? Those patients had a significant improvement in the renal outcome and a really significant outcome in the CV outcome. CV death, non-fatal MI, non-fatal stroke, as well as heart failure, as well as also worsening of renal failure as well. So the characteristics of these two agents are they are non-steroidal MRAs, and they have no effect on the androgen or progesterone effectors. They're higher potency than steroidal MRAs, and they're balanced between tissue, heart, and kidney. So selectivity and also less effect on the renal function. So I think while you can remove the word CKD and put CHF, it's basically the same thing. You can remove type 2 diabetes and put CHF. So this triad of the effect, the beneficial effect of RAAS blockade, MR antagonists now, and SGLT2 inhibitors we're seeing in terms of inflammation, hemodynamics, albuminuria, endothelial injury, oxidative stress, glycemic effect, and fibrosis are really this triple therapy that's life-saving across the board in our three most major diseases. Now, what's the impact on potassium? There you go. So compared to placebo in this study of patients with CKD is almost a flat 4.37 with finerinone, 4.38 with placebo across the entire 44 months of the study. So that's a remarkable difference in the mechanism. So the summary is that by using this more selective, better agent, patients with optimized RAAS therapy, mortality and morbidity from CV events 14% and CKD progression 18%. Why? Because the potassium was taken out of the equation. And the number needed to treat was pretty small here, 29 and 42. So the consensus documents are also telling us that we have to actively manage hyperkalemia. Now, the new agents aside, they've not been included in the guidelines, but if you look in the ESC guidelines and in the current version of the ESC guidelines, it's fairly clear that we are now recommending novel potassium binders in patients with heart failure. The ACC, again, treating hyperkalemia with the zirconium salt or the potassium binder patiromer in order to enable MRA and other RAAS uses, and also to allow further up titration in heart failure with or without CKD. So that's kind of a difference. So in summary, we have to rethink hyperkalemia as an obstacle in RAAS therapy. It's frequent. There's recurrent events in patients with heart failure, CKD, and diabetes, especially on RAAS therapy. Obviously, the presence of hyperkalemia cannot be ignored. It has worse outcome and increases. Now, the guidelines are recommending RAAS therapy to improve patient outcomes. Older guidelines are now changing. They used to talk about discontinuing or decreasing therapy. Now we are going to continue RAAS therapy with management. Re-challenging with RAAS therapy does not occur because people are so afraid of hyperkalemia, and that causes worse outcome and mortality. And now the new heart failure consensus guidelines in diabetes and heart failure and CKD recommend active, aggressive management of hyperkalemia with novel binders, or as we saw, newer agents that are still in play like finerinone and finerinone that are selective and do not cause hyperkalemia. So I believe that's really all I have today, and thank you for your time.
Thank you. Excellent, Dr. Hani. You know, we already had a discussion on this hyperkalemia and heart failure symposium, and one thing you mentioned here, I think is important, with the new MRA, and I think, you know, having a new medication which has less effect on renal, you know, and potassium especially, that's very, very helpful, because we don't want more medication. we want to reduce, you know, we want to use the medication which has got less deleterious effect. I mean, Dr. Sharif, you want to maybe comment to ask
so
here?
I think, just to simplify, because it's very complicated, you know, the story. So what is the take-home message from your advice that don't stop, reduce, and re-evaluate? Do you accept that?
Yes, I think that's exactly right. Thank you for that brilliant summary. I think the key point is the easiest thing to do is to stop or reduce. That's not the right thing. First of all, let us consider that the highest risk is in patients in whom we stop or discontinue or don't reach the maximum dose, and that is cardiovascular death, okay? Number have to look at secondary things. Most of our patients love to eat dates. The dietary source of potassium is very important. So dietary counseling such as mango, banana, orange juice, and specifically dates, high amounts, really can be a significant, easy way to reduce this problem. And now we have tools that are better in terms of the long-term management of hyperkalemia, right? Either potassium binders or the newly approved hyperkalemic reduction medications as a maintenance therapy.
Thank you very much. I think we can proceed to the final presentation today. Dr.